elderly. But I do ask that before next week you read over the topics in the book, and I'll be ready to go on that, on the neurocognitive disorders with the elderly. Okay? So today we'll kind of wrap up anxiety. Do you ever wrap up anxiety?
No.
No. And then we'll go over eating disorders, and then that will be it for the week. Let me get myself lined up. One. Okay, so with the anxiety disorders, remember we talked about we had some specific things that we wanted to cover. There's a lot of different anxiety disorders in the book, but you're looking at obsessive compulsive disorder, post-traumatic stress, panic disorder, phobias, and generalized anxiety. Now, those are more, those are the specific conditions, are not necessarily diseases on them, but those are the conditions underneath the umbrella of anxiety. But remember, anxiety itself, we talked about being on a continuum. Mild kind of helps you function a little better. Once you pass that, you're not able to function. And once you get down to where you have the physical symptoms, ooh, my heart's racing, palms are sweaty, I'm breathing faster and all. We said that's the point where whatever you're doing as a nurse, if it's not trying to get them to stop that, they're not hearing what you're saying. It'll be all right. We got to get you down to surgery. Anesthesia's coming in just a minute. Just go ahead and let me tell you what to do. And they're like doing all that. They're not hearing what you said. You got to stop and deal with that anxiety. Okay? That'll be the time when they come back and say, I don't remember you telling me that. Of course they didn't. Their brain's not able to organize thoughts once you're in that symptomatic mode of anxiety. Okay? And so underneath, more specific anxiety conditions depend on their symptoms, okay? And where do you go to get the diagnoses? DSM-5, right. That's where you would take your assessment of this client, or the provider would take the assessment of the client. How long you been having these symptoms? How often does it happen? Remember we talked about with generalized anxiety disorder, well, it happens more often than not that I'm anxious. How long has it been going on? Is it just you had some traumatic event happen a couple of months ago and it's just been going on that long, or have you been dealing with this for 6 months? So duration, intensity, like we talked about in Unit 1, helps you determine if you have any of these conditions underneath the umbrella of anxiety. Generalized anxiety disorder, or GAD, you'll see it abbreviated, is characterized by excessive worry. And you can find it in your book on page 286. We said PTSD, was you had something really traumatic. Kind of the benchmark for PTSD is something that happened in military experience, or it could happen in a lot of areas. There are certainly nurses that have PTSD and things that have happened to them. You end up with this disorder re-experiencing what happened. You'll hear people say, well, I was just back where it happened. Page 310 in your book. It can interfere with their sleep. It alters their mood because they're working to avoid having those symptoms come up. Children that have been abused might have PTSD too, if they can remember the events.
And rape victims too.
Yep, rape.
Like all those old battered syndromes, battered wife syndrome, that's all now
Under more,
PTSD, right?
it depends on if they, well, I don't know.
I remember there used to be like the battered woman syndrome.
Syndromes, and now it's more under PTSD. I'd have to look to see what they all turned into. But that's a good point, probably. And do all people that have had a crisis in their life or a really traumatic event end up with PTSD?
No.
No. And that's, depends on coping mechanisms, things we talked about in Unit 1, resiliency. It just depends on the person. Acute stress disorder is different from PTSD. That's the other one. Acute stress disorder is just what it says, acute. It happens more quickly, comes on more quickly, and tends to get over with more quickly. Acute stress disorder. They had something happen. These symptoms arise more quickly. They're able to resolve usually more quickly than PTSD. PTSD can happen a good bit longer after the event, and it can last longer than just the acute. We talked about that table on table 15.4 about the different types of phobias. So just briefly go over that. You don't need to end up being an expert in every single phobia that's on the earth. But one of the big ones that we didn't talk about yesterday that we do need to talk about that's in your syllabus is agoraphobia. Agoraphobia. Agoraphobia, we will get into that in a minute. Going over my notes here. I always go home after I teach y'all and make sure we covered it all. Let me hit a couple more points and then we'll get into agoraphobia a little bit, okay? So on page 293 in your book, I just wanted you to look at assessing the level of anxiety that a client's in. And that's what I talked about earlier. If I look at the patient and they're telling me, if they're flushed and they're telling me their palms are sweaty and I'm getting dizzy, then that's my assessment right there. Okay, they're symptomatic with this anxiety, and then I know what sort of actions I need to take after that. Okay, it's what the patient is telling you and what you're seeing. You might want to check a pulse and all, but if they're telling you I've got blurred vision, I feel dizzy, I think I'm going to be sick, or my palms are sweating, and I can see her, I don't need to get into some heavy-duty assessment and then go, well, I'll put your teaching off for a minute. You know, you can look and go, okay, the first thing you're going to do is some relaxation techniques with that client. Take a few deep breaths. Why don't you close your eyes? I'm right here with you. That's the big one. I'm right here with you. I'm not going to leave you. You're okay. Talk to me. Get in their line of sight. I'm right here with you. I want you to take a few deep breaths, and you can do all of that. You can be doing your further assessing, but just those things right there let you know you need to do that. Table 1511 goes over that a little bit more. That will help you study. And if you can get the client out of the situation that's making them anxious. If they're in the day room with a bunch of people and they're a nervous wreck and they're and they're really starting to have symptoms of all this anxiety, and you know that they're struggling with, say, being in a group, being out of their room, being in a closed-in area, that's the person. Okay. I'm being a little patient. I think we have some issues going on back and forth. Try not to do it too much. That's where you can look at that client and say, why don't you come with me? I'm going to walk with you down to your room. Separate them and give them some space and some air. We had a patient one time, and it happened like 2 or 3 times in a row, that we were prepping like for surgery, and we'd give Reglan and Zantac, and to be honest, I can't remember which one, but a couple of patients in a row were like, you got to get this catheter out of me. And it was like, I just put it in. No, you got to get it out. You got to get it out. I can't have this in me. And I'm like, calm down. I just don't think I can do it. Flushed, well, I'm going home. I mean, it was like getting out of the bed. Just this patient that was fine a minute ago, and it was like, calm down, talk to me, let's get you calm. And literally one reached the point where it was like, had to take the catheter out, had to take the IV out, had to write discharge instructions, get an order from a physician, and they left and they went home. They were having a C-section too, and it was like, I'm gone. And it was like, okay, well, when you decide to come back, let your doctor know. It was just such a level of anxiety that we just could not get her calmed down. We actually discharged her, and then the doctor called back later and said, I talked to Miss So-and-so. She feels better now, and we're gonna bring her back in. And we brought her back in, and, but that's, when we're talking about an anxiety level, that's the point you can reach. Now, luckily, we're in a scenario where we could let her go home. Had we been in a stat C-section with, baby, and we would have had to have, yeah, well, we need some meds, at that point, the talking, the eye contact, and the holding her hand and all probably wouldn't work because you're rolling down the hall to the operating room. But do you have to address it? Mm-hmm. You can't just go, she needs to calm down. Because it's not going to go well in the operating room. Jump over the bed rails on you. It's that level of fear and all. You have to address it. And good nurses can kind of see, as being an RN, as part of your assessment skills, you stay on top of it. You can kind of tell when your client's changing, and you can see that anxiety coming on. And it's good to try to work on those signs and symptoms early. So kind of a recap there. All right. Agoraphobia. Let's talk about it. It's on page 285 in your book. And agoraphobia, a lot of people, if you ask somebody what's agoraphobia, they might say, oh, fear of closed spaces or fear of something specific. But really, agoraphobia is kind of a blanket description of a fear of being somewhere and not being able to escape. Well, what if I get in that elevator and something happens and I know I can't get out until it gets to that next floor? It's that fear of not being able to leave and get away or get help. It might be the person that's, and a lot of times agoraphobic people are content at home. It's safe. And that's where you may hear about somebody that's reclusive. What if I go outside and something happens to me and I lose control and I'm out there by myself and nobody finds me and nobody can help me? Or it might be, what if it might not be the fear of the flying, but it could just be public transportation in general. I'm not driving the bus, so I don't want to get on that bus because I can't control getting off. So I really am uncomfortable getting in that cab. Because what if I get in the cab and they're driving really fast and they really scare me and we're in the middle of the street and I can't get out of the cab? See, that's maybe I might have had a smidgen of that. I have a little control thing too. I don't really like somebody driving the bus, so I can tell this story pretty good. And I've had some others, and I always encourage y'all, if you ever feel comfortable to share something, speak up. I don't have to be the only one talking, but I will tell you, I've had some kind of traumatic things happen in life, and you kind of get a little bit of that agoraphobia, and it's hard to put your finger on it. But I've actually canceled a few plans, right at the last minute, thinking, I don't want to go. And that's really not me. And then you have to call the people you're going and going, I'm not going to go. And they're like, what happened? Well, something came up. And really, it's just me going, I don't think I can stand being there because I may want to leave. And I've even thought about, I used to like going on a cruise, and then I've thought about, I don't know about that. I can't get off unless they get me with a helicopter. So sharing that with you. Only to say that it can be very vague or a little specific, but really it's just the person being afraid of not being able to get away. So if you're taking care of that agoraphobic patient, I can remember in nursing school, my patient at the in the mental health unit, I think it was at Singing River. We were there like an 8-hour day. I spent the whole day in the room with her just trying to get her to come out of the door. And I can't believe they left me there. Looking back on that, I'm like, where was the nurse? But it was like, are you ready to go? I was her person. Are you ready to go eat breakfast? Mm-hmm. And she, I can't. And I was like, okay, well, I'll sit with you. I'll sit with you. I'm ready to go to breakfast. Okay. And I'm at the door. And she's like, and it was so painful. And I remember coming home, it was so cramped all day. And then
8 hours of that.
Because I was like, well, breakfast is over.
Now lunch.
Setting goals. We gotta go. You're going to lunch. Then she started kind of ruminating on it and coming up with the reasons why she couldn't go. Because she knew I could tell, wow, you can't leave. And she was like, well, I'm kind of concerned I might need to go to the restroom. And that's actually one of those things with agoraphobia. They may be even afraid of public, incontinence in public. Well, I'm afraid I may need to go to the restroom. Well, I'll bring you back to your restroom. I don't know. What if I can't find you? Everything I said, she had something for it. And that's the pain and the anxiety of something like agoraphobia all day long, all day long. So if you're taking care of this patient, one of the outcomes for them may be something as simple as, we're discharging you home and here's your goals. So what are we going to shoot for this first week? I'll sit outside on my front porch for 15 minutes 2 times this week because they're outside their house, they're outside their safety zone. Or, maybe someone who's a little more functional and they work and everything, they may do something like, I'll ride the elevator in the mornings. Some people, yeah, so it's going to be little steps that put this patient in a place where they're not in their safety zone anymore. Okay, so that is kind of agoraphobia a little bit in a nutshell. I've got some got a video too that we can watch a little bit about the therapy that you do. I got a good video I'd like to show you about cognitive behavioral therapy. With this type of disorder, remember when we talked about in Unit 1, and y'all hear me talking about Unit 1 a lot, we just revisited, but we talked about Freud and the psychoanalysis and how he thinks a lot of things that make us have the problems we have now happened in our childhood. So we lay on the sofa and we tell him our problems. Well, back when I was a child one time, Mama didn't do this for me. And you try to talk it out and dig down to see what's in the subconscious and all, and you try to solve your problems that way. But we talked about cognitive therapy was about changing the way you think, and behavioral therapy is changing the way you behave. So cognitive behavioral therapy is changing the way you think so that you can change the way you behave. Okay, and so that's what the type of therapy you're doing with a lot of clients that have these anxiety disorders. Every time, let's say the obsessive compulsive patient, they're having those obsessive thoughts. Remember, they're intrusive. I'm a bad person. Oh, you're dirty. It keeps coming in your head, and you can't get rid of those thoughts. And so the compulsive behavior makes you feel better. I'm going to wash my hands again. With cognitive behavioral therapy, there's all sorts of activities you can do so that, say, when that intrusive thought comes in, you actively say journal it and write it down. And what was happening when that intrusive thought came in. So you can start to see a pattern. And then you can think, well, every time that intrusive thought comes in, oh, this will never work, you're never good enough to do anything. You consciously tell yourself, no, people do good things every day that they didn't think they could do. I mean, whatever you're working out with your therapist, it's actively trying to think differently than what your brain is telling you. And so a lot of that type of therapy works. People, if they have the therapy and they work on their thought patterns, that helps. And then that can in turn kind of help your behavioral patterns. And then there's plenty of behavioral therapy where they give you, tasks to do that can change this. So a lot of, as you're studying, you just remember cognitive behavioral therapy, and that helps a lot with these anxiety type orders. Because there's, it's vague fears with anxiety. And there may be some serotonin issues going on. That's why they give them SSRIs, antidepressants, with some of these anxiety disorders. It does help. And so the thought is keeping the serotonin levels and all adequate will help. But this disorder is not all biologic. A lot of it is just your brain thinking things, worrying incessantly. And so biologic treatment may not be the only thing it needs. It needs that cognitive behavioral therapy. Does that make sense? So that's why you'll see a combination of things, some medication and then some therapy to help people work through and be more functional. And the goals of their outcome goals are gonna be that they're more functional. Whatever it is with the anxiety, that they're able to manage their anxiety in a way so that they're not homebound, or they're not stuck washing their hands a million times a day, or they're not exhausted and miserable from being anxious the majority of the time. So, one other thing that we talked about in Unit 1, but since anxiety disorders have SSRIs, serotonin reuptake inhibitors, as one of the medications, one thing I kind of wanted to go up a little bit more over was page 267 in the serotonin syndrome. I think it's table or box 14.2. Remember, the serotonin, the selective reuptake inhibitors means it's inhibiting the reuptake of the serotonin. So it's swatting it back in and keeping it on the court, keeping all the players on the court so you can get the kitten feelings passed along. If you're putting too much of that serotonin back in, and then you say, really where you see this a lot is where you have an SSRI in combination with an MAOI. Because remember, the MAOI was a monoamine drug. It's cutting down on the amount of monoamine, so it doesn't break down as much serotonin. So it's contributing to a higher level of serotonin, and the SSRI is contributing to a higher level of serotonin. And all of a sudden, you got all this serotonin, and you may get too much. And that's where you get the serotonin syndrome. That's why when you're listening to the drug advertisements on TV, sometimes you may hear, don't take it with an MAOI. That's one of the reasons you may hear it. So make sure you know those signs and symptoms, because it can lead to death. Okay. It can lead to death, so it's a serious, and that's why patients on these medications need to be monitored closely by the provider, making sure they're staying on top of what the combinations of the meds are, which ones tend to lead to the syndrome more than the others. And they're the symptoms you would kind of think. It kind of makes restlessness, tachycardic, fever. Okay, they've got so much of the serotonin, which is used for transmission. You end up with these.
Would they be really happy? Like really happy?
That's a good question. It's kind of like they've maxed out what they need to carry neurological messages, and now it's just doing other stuff. But it doesn't go into that a whole lot in the book. What they're gonna feel bad. Okay, they're gonna be sick, or they might feel happy. Restless, tachycardic, increased blood pressure, delirium, mood swings, diarrhea. You know, that's where they have the constipation, like we talked about with a lot of the others. So, I mean, they may be to the point where you're putting a cooling blanket on them for the fever. Anticonvulsants to make sure they're not having seizures. Probably be in ICU. And so when you're teaching clients about that, this is one thing you want to make sure you teach them about. You know, if you start feeling bad, anything like that. And like I said again, the combination of an SSRI with an MAOI really increases the risk for this. Your meds for anxiety. One group that we didn't go over a whole lot in Unit 1 was the benzodiazepine. I again would encourage you to look in your drug book and your textbook, but ATI is a good kind of summary place to look at your meds. Your benzos usually end in PAM. We said that they're the diazepams, lorazepams, but not all of them do, but most of them do. And these help a lot to relieve anxiety, so you will see those used a good bit. I actually used to get a prescription for one Valium to take when I went on a cruise. because it was a really big ship and it was scary and had all the kids on it and a bunch of passports, and what if I left somebody in Mexico? And so my doctor was like, this is really sad. I worked with my doctor, and I was like, oh, I'm going on a cruise. I'm taking somebody else's kids. You know, my friends were bringing friends, and they all had little passports, and ship's really tall, and they were all like, oh, look. And I'm like, don't look over there. Don't look over there. And I was talking to my doctor one day at work, and I was like, just getting on the and then one time I was going with my husband, and we were going, and we got our little, and I mean, we had like free points, so we were going free, and it was really exciting. And he goes, we're going up the ramp, and he goes, oh, I forgot my passport. And I was like, and we're in Texas, because we had to go to somewhere to get the cheap cruise, so we had to drive a little ways. And I went, and he went, just joking. Yeah, I took my suitcase and threw it down, and I said, I am going to Mississippi. He's like, I'm joking. I'm like, that's not funny. You know I'm the control person of the family. Because he wasn't.
Would those situational cases still be like a mental health?
No,
Like
I wouldn't
those-
have met the DSM-5.
No, because like people with dental fright, like I'll tell you, I keep value in the house only for when I go to the dentist.
To the dentist, right, and that's a good example.
Yeah, like, I mean, the
We
one
would
situation.
have to look. There is acute anxiety that can maybe, but I still don't think we'd be diagnosable. It's just using the medication for a one-time periodic, and you know what it is. Sometimes your dentist will prescribe it. You
Right,
know?
no, mine does.
Yeah, and so
I
that's
get
not
that.
like, it's like giving somebody a little bit of something to have an MRI. We know they're gonna be a
Crazy
nervous.
in that
You couldn't shove me in that machine. I mean, it'd be like the cat. So, but he'd give me one. It was literally one in a bottle, and it would be like
Right.
once every 3 years. But he's like, you know, people really shouldn't be this miserable, Leslie. And I'm like, but it makes sure that we don't forget anything. No, he said, no, it doesn't. And I knew that. It don't make you not forget anything. It makes me more apt to forget something. So y'all can use that as an example when you're studying for your exam. Once you reach a certain point, it ain't helping. It's just making your family miserable and your blood pressure higher. So, and we see that so much as nurses. You know, you'll be taking care of a patient, and you think what you're doing to them is just fine. And then you look over at them, and they're a wreck. And you're like, are you all right? And they're like, they're not all right. We, of course, you know, so as nurses, you got to be assessing that. And just because we've done it 40,000 times, they haven't. You know, so just never forget that. And it's funny, in labor and delivery, everybody always like, how many times did the dads pass out in the delivery room? I've only seen one guy pass out in the delivery room in 30 years. And he was sitting down, and he just slid out of his chair. He wanted to wear his cowboy hat, and we put a blue hat on it. And he kind of leaned back, and I thought he was talking to me. I was like, you doing okay? You doing back? And he leaned back, like, oh no, he passed out. And he just kind of moved. I just, yay! Easy. Most of the time, if they're going to pass out, it's with an epidural. And it's almost the fear of the unknown. They are on the other side of her. They don't even see the needle. They can't even tell what they're doing. And I almost feel like it's that, because what's anxiety? Kind of that fear of the unknown, a real vague fear. They just see her bent over, and they know she's kind of hurting, and they know there's a needle back there. They don't even see it, and then that's when, boy, it's like, I'm dizzy, and then hardly any warning. It's acute.
So that's why they started not letting them in until that was done already?
Yeah, usually, because sometimes you can like let the dad hold them, but you're kind of asking the dad to step in and do your job. So I'm saying, I'm assessing that you can do my job, and then if you plunk over and she plunks over, and well, who made that decision? I thought he was okay. I usually always hold my own patient, because they'll be looking fine. And then a little bit of a warning. Leslie, I can't, it's like, you can't get around the bed fast enough, you know? So, usually, and I always, and if they want to stay, I put them in a chair. Put a guy in a rolling chair one time. He had a leg cast. And and I put him there just for a minute. He'd come up, and I set him there, and I heard a big ruckus. He had stuck his leg through the rail because it made it feel better. And then she said, hold my hand. And when he reached over to hold her hand, the chair shot. He was on the floor with his leg in the bed rail. Because this was back before we had birthing beds. We didn't have birth. I was back in the Stone Age, y'all. We had those old bed rails that went clunk and the whole rail came down, clunk, for a labor bed.
Oh, yeah.
And so, yeah. So, no rolling chairs. Don't ask them to do your job. Even if they're looking good, they may not. And that's in any case. Because some people, another time I had to pull nose packing out, and it was like 4 yards of packing, so it was going to be yucky. And the mom's like, I can do it. And I was like, I don't think you want to do this. I can do it. I was like, I'll let you just sit here with me. Well, I'd rather do it. I said, well, I know, but let me do it. And she was kind of miffed, and I started, and all I could hear was, oh. You want to do it? So, you just find a tactful way, because people want to participate and help, but sometimes if you know it's going to, she was like, whoa, that was way more.
Then you're going to
than
have two
what I-"
patients.
Yeah, you will. She said, there was way more in there than I thought could go. I was like, right? That's so much. Oh, y'all. So just, that's one of your roles as a nurse, is running that room and keeping up with people, whatever that room may be, a clinic job or the ER or a med-surg floor, Nobody else is watching out for all that stuff.
The other case for people passing out, that anytime, especially in outpatient, blood work.
Yes.
Know your patients that pass out.
Yep.
Move them from lab and put them in a room.
That's right, because they're good. And if they tell you things like, I'm real hard IV stick, usually people start an IV here, and I've literally seen people go, well, I'm going to go somewhere else. Why do you do that? Look, at least look.
Yeah,
At least look. And if you feel like you can't get it, then say, I see what you're saying, but I know my skill set. I feel more comfortable with this pain. I'm just trying to save y'all some pain. Oh, yeah. Do you need us?
Well, I'll wait for you to break.
You're okay.
Okay.
We've deteriorated.
Well, I heard y'all laughing, so I was
Yeah.
like, maybe it's not too crazy. I just have two things. Brittany Suber, did you get your mentors?
Yeah, they didn't get my contact information.
Yeah, they just got it today. And then Lance Crawford. Dynasty Blackson has not heard from you.
Are you still on me after
No, I just teach. I'm old and just teach. I've thought about, but she doesn't know. Then I go to clinicals with y'all.
It's all in you right here.
Okay.
And then there's several in that level 1 class that says they have not heard from y'all. So just shoot them a text because they are in pure panic mode.
We can talk to them about anxiety.
Because
How you feeling?
I walked in and they were like, I haven't heard from my mentor. I was like, well, give them a couple days because
They had a test.
They had a test. Just give them a little time. I said, they're just as anxious as you are.
Y'all can get together with them and practice your assessment skills. On
They're going over ATI and stuff, and I think a lot of them want to meet face to face, and y'all show them kind of how to work through ATI, work through Elsevier, work through Evolve. Probably so. Because when I walked in, Miss Copeland was like, "Oh, we're just going through ATI," and I saw a bunch of them going. And I was like, "Oh, I remember that." So, but just send them a text this weekend, and if you don't, I'm coming around Tuesday. If you don't get a response back, write your mentee's name and the phone number you have, and I'll hunt them down and make sure it's the right information. Okay? Thank you.
And thank y'all for doing that.
How about I email it to you?
That's fine.
Okay, great.
Or Facebook, either one.
All right, sounds good. Do y'all need anything else, like from me?
Y'all need anything?
You're
Okay.
awesome.
Thank you.
All right, thanks.
Thank you so much. Okay, so, drugs, benzos, your PAMs. You have a different, kind of an atypical anxiolytic that's new in the anxiety unit. It's a Buspar or Buspirone. If you're working in the hospital, you've seen it, or long-term care. It's just a little atypical. It works well with some clients. Works well with some clients with anxiety. It's in ATI on page 116. 116. Again, let's see, table 14.6 in your book is a good place to review your antidepressants. Table 14.6 in your textbook, and ATI page 116 is that buspirone. Now, we've talked a lot about the SSRIs, the Prams and some ENs like Celexa, Lexapro, Prozac. But also in this unit is SNRIs. And that one doesn't focus so much on some of the serotonin, it's focusing on the norepinephrine. It's that other neurotransmitter in the gap, you know, and so the SNRIs kind of help keep from absorbing all of the norepinephrine, which also has a good effect for some patients. And most of those end in I-N-E. And if you want to know the name that you would hear on TV and all, these are the Pristiques and the Cymbaltas. And sometimes you'll hear people saying, well, you know, whatever med they were on, Celexa wasn't working. So a lot of times you'll hear provider will switch them over to something like Pristique. And so now you can understand that that first med they were on was focusing on serotonin, and now they're going to look and see how focusing on the norepinephrine might help with the symptoms better. So now you can listen to those TV ads and know it. You might have already known. I'm sorry. You may have already known. So those are the focus for the meds on anxiety. Now, as far as anxiety, talking about the actual causes, you know, we talked about some things were just some behavioral things that they were doing or some cognitive things that were going on. We need to change the way they're thinking and all. Now, it does talk about in the book that there is a significant biologic reason why some people have anxiety disorders. And they do notice that anxiety disorders are sort of clustered in families. You know, you may not see everybody have it, but there'll be a cluster of people in the family. And I know for myself, my like cruise ship thing and airplane thing, my grandmother was exactly the same as me. And sometimes I wonder, did I pick up some of it subconsciously? But I think some of it, because she tried to keep it, you know, she didn't act very flustered. She was a pretty cool cucumber, but there was just a few things she was not going to do. Get on a plane was one of them. But, and then I see some things with my daughter too. So anyhow, there can be a biologic factor in why people have anxiety disorders. It can also be associated with trauma or things that happen psychosocial, things that happened in the home. Some medications can give you anxiety symptoms too, you know, maybe something that you're taking. But I think with that, we've kind of gone over everything that I wanted to cover. Do y'all have, yeah, let me make sure. I always go back to that. Yeah, that's about it. I think we've pretty much covered anxiety. Now we're going to talk about eating disorders. Okay, so chapter 18 in your book is eating disorders on page 343. And We're gonna focus mostly on bulimia, anorexia nervosa. And also binge eating syndrome. Binge eating syndrome, a little different than bulimia. So the big deal is kind of, first of all, telling the difference between these two eating disorders. With anorexia nervosa, the defining factor is an intense fear of gaining weight. Intense fear of gaining weight. There's a body image disturbance. They can be 85 pounds and 5'6" and think they're fat. There's a body image disturbance. They can't see themselves accurately, and a lot of it's based on that fear. They need to, body weight needs to be 25% less than their original body weight, and there's no known physical illness. So we've ruled everything else out, and you're down to this eating pattern. That's why this person is losing weight. Now, on the other hand, bulimia is purging. They eat, and then they make themselves, or use laxatives. They're aware of their abnormal pattern. They know what they're doing is abnormal. And they have a fear of not being able to stop eating voluntarily. When they're on the binging phase, it's just like, I cannot stop eating. I can't get full. Just eat. And then they're depressed after that. So it's that circle. The client with bulimia differs from the client with anorexia nervosa in what way? How do these? Read them all. Read all the answers. I know we haven't gone over it.
Normal weight.
A distorted body.
Let's see. They maintain a normal body weight. Bulimia does. The anorexia nervosa is more the distorted body image
Or
and the
nothing but
rigorous
skin and bones.
exercising. Because remember what's driving them, that intense fear of gaining weight and a distorted image of themselves. And the purging from bulimia is not so they can lose weight. It's to get all that food out that they just ate, and that's those
So they
feelings
don't
of
gain
guilt
weight.
after that, and they don't gain. And they don't gain. They kind of equal out. Theirs is more of almost like an OCD behavior. That, you know, they eat and it's too much, and then they vomit because they feel guilty afterwards, and then you feel guilty and bad, and then you start the cycle again. The anxiety builds up, and then you eat and you eat and you eat, and then you purge. They go through cycles. So, and I know we're at the beginning of discussing it, but I like to kind of throw some questions out just as we get going. So a subjective symptom, is that something you can see? A subjective symptom? No. They have that fear. But these other symptoms, you will see. From the starvation, they'll start to grow the fine lanugas, fine hair, especially on their face. Hypotension, possibly a 25-pound weight loss. Okay. Bless you. If you look on, just for your notes, on page 344, there's a nice little box comparing the two diseases. It's box 18-1. And if, what's that?
You said 18-1?
Mm-hmm. Should be. Page 344?
334.
Really? Okay. Okay, 334. Okay. Eating disorders have a higher mortality rate than any other psychiatric disorder. So we may not hear a whole lot about it, but what do you think becomes the lethal problem with an eating disorder?
Nutrition.
Yeah, it's the fluid and electrolyte imbalance, especially the electrolytes. This is more, you see more females with these. Hang on a minute. Hello? Hey. Okay. Do you know what? Sorry, y'all. Okay, so that ratio of women to men is 10 to 1. The last time these statistics were done. And this is usually something that impacts people in adolescence, somewhere around age 14 to 16. It's cross-cultural, not really limited, but slightly more common among Hispanic and Caucasian. And we said the mortality rate is higher than other psychiatric disorders, and the suicide ratio is slightly higher too. So, comorbidity for eating disorders, one of the ones that's significant is the depression, 40 to 70%. So hence, there's where you probably get your suicide. I know a lot of times when we show videos, people, this one is fairly new. You guys may have seen it, but I thought this was interesting.
Because for me, I know I've made videos.
She's bulimic, and she's only like 19. So when she was talking, it sounded like she was a good bit older. So everything she'd been going over with the bulimia was fairly recent.
It's about.
And she's talking about her teeth, but she's kind of just talking about everything that goes along with it that has happened to her.
You know, my battle with anorexia, but I actually suffered from bulimia for a much longer period of time than I did anorexia. Obviously, bulimia short term is really bad for your body, but the damage that it does long term can be catastrophic, and I still suffer from some of the consequences of being bulimic for such a long period of time, like to this day. Whereas with anorexia, I don't really suffer with that anymore. So I think for me to talk about bulimia is a lot harder, just because it still affects me. So, in this video today, my fellow friends, we're going to talk about bulimia and the consequences of bulimia and how you can recover from bulimia, because bulimia is a bastard. It's a nasty, nasty illness, and I want to make sure that we get rid of this illness from everyone's lives, because it is devastating, it's disgusting, and I ain't happy with it. So we're going to get rid of it, okay? So, first off, we're going to talk about the things that bulimia does to your body. Not to mention the fact that you're going to be incredibly dehydrated, obviously, because you are purging quite a lot, which depletes your body of the hydration that it needs from the water, so you're going to have nasty dry skin. Guard hands. If you are making yourself sick using your hands, you're going to be rubbing your knuckles across your teeth a lot, which leads to permanent scarring, red eyes, a thing called hamster face, which is where you get really puffy cheeks, a high blood pressure, severe headaches, fatigue. Not to mention, you rot your teeth. You damage your teeth. In case you hadn't noticed, you only have one set of teeth once you're an adult, so if you damage them, that is it. No more. No comprende. You're screwed. Yeah, and everyone loves it when, you know, you've got no teeth. So, bulimia damages the nerves that signal to your brain when your stomach's full, and that's often irreversible, the damage to that. So your brain doesn't communicate properly with your stomach. So, that's a good one. Extreme bloating, ulcers in your mouth and your stomach. The malnutrition effect of not getting enough nutrients can damage your bone density, it can damage your kidneys. If you are suffering with bulimia for a number of years and you're a female, you can damage your ovaries, like your reproductive organs, which can affect, obviously, children in the future. It can also damage your periods. For people that have been suffering from bulimia for a number of years, there is a chance that the damage that you do to your ovaries and your periods is in it can't be reversed. So in some cases, being bulimic.
Now, some of that, you know, we're taking everything that she's telling us with a grain of salt. We'll go back over stuff, but we more just wanted to hear the perspective on it.
Can leave you infertile, which means you can't have children, which is something that you might want to think about. The impact on your brain and your emotions in terms of constantly feeling worse. You make these kind of connections in your brain that when you're full up, that's bad, and so you feel these feelings of disgust, which are just only reinforced when you then allow yourself to feel better because you've been sick. Those negative pathways are really hard to break, so the more you do it, the more you feel better for doing it, which means it's harder to stop doing it. So the best thing to do is just not go down the route in the first place. People who are bulimic can suffer from heart attacks quite easy, especially if they're using laxatives, because they cause electrolyte imbalances, which can cause heart attacks. The acid from your stomach going constantly up through your esophagus, out of your mouth, can leave you with ulcers in your mouth, a sore throat, a swollen throat. It can bleed, so you can end up spitting blood, being sick, full of blood. You can actually damage the lining of your esophagus. You get holes in it. Bulimia is messed up. It's really not nice. In terms of the things that have directly affected me, my teeth have rotted. It's just kind of hard to talk about. So I essentially damaged my teeth really badly, to the point where 2 of my teeth are dying. Because of the damage I did to them when I was bulimic. And the other ones don't look so great either, to be perfectly honest with you. And it sucks to be 19 and to have dying teeth, to be honest, because your teeth are supposed to last you like pretty much your whole life. And that's not the case. I don't know. And I've got to have like a root canal done, and I've got fillings in my teeth at the back, which sucks. And I suffer a lot with acid reflux. It got to the point where like it was so unbearable, the acid reflux. I was in agony a lot of the time. It's really painful. Like there have been times we've gone out to dinner and I'll literally be in tears because of the pain of the acid. And I'll take Rennie upon Rennie and it doesn't do anything. Luckily, over the past 2 years, it has calmed down a lot. But the acid reflux was really hard initially because I knew that if I was sick, I felt like I could get rid of some of the acid and it wouldn't hurt as much. So it's hard to fight that off when you're in pain, to be like, I know how to remedy this, but you've got to be like, actually, sitting here and suffering from the acid reflux is better than making myself sick in the long run. So you just have to kind of like battle that out. I damaged the lining of my esophagus so badly that it's not the right shape really anymore, which means that I can get tablets particularly stuck there. So things like the size of a paracetamol is enough to get wedged inside my esophagus. And what will happen is I'll try and like drink water to get it down, and the water will sit on top of the tablet. And then eventually my body has to try and like heave up the tablet, and it's the most excruciating thing ever.
So, you know, we kind of get the point with what she's talking about. It doesn't just go away once you stop. The damage can be just devastating from the acid coming back up. So we talked a little bit about what the diseases are, and you've got your PowerPoint. You can go back in on campus and study, and I'll pull it up for today. But these eating disorders are closely associated with like mood and anxiety disorders and oppositional defiant disorder. We haven't gone over that. You know, you'll hear a lot of times people diagnosed with oppositional defiant disorders when they're children or adolescents, sometimes with ADHD or something. But and it's a disorder. Can't talk. 22% of the people with anorexia also have OCD, so the obsessive compulsive. And 25% of the people with eating disorders, I think mostly bulimia, also have borderline personality type. And if y'all interviewed me yesterday, I had the borderline personality disorder. We'll go over those more. But it has a lot to do with trauma and manipulative behaviors. And then binge eating disorder is closely associated with depression. 20 to 50% people with the eating disorders had some sort of childhood trauma. Kind of makes sense because it happens in adolescence. It's not a disease, but there are some strong genetic factors going on with eating disorders to think that there may be something genetic contributing to it. Used to the theories on why people have them were varied. You know, difficulty separating from the family, a defiant person, you know, a teen. They're kind of looking at now the current belief with the eating disorders is it's a learned behavior that gets positive results. We have a lot of influences in the media and all about being thin or the perfect body image. It's just constant barragement of that on everyone. And then it may be that these eating disorders, they get the response that they like, so they get a positive response. But really the jury is still out on exactly why people end up with them. So anorexia nervosa, preoccupied with food, may suppress the desire for food. And the term itself says it's a loss of appetite, anorexia, but really it's suppressing that need for food and all. They'll have sometimes a lot of little weird ritualistic behaviors with their food, like cutting it into little teeny pieces or rearranging their food on the plate, you know. And just remember, it all goes back to that fear of gaining weight. Compulsive behaviors regarding food. They'll also use laxatives and diuretics and excessive exercise to keep the weight off. And then wear baggy clothes to cover up around the right people, the weight loss. What do you think your number one goal is if you've got someone inpatient that you're treating for anorexia nervosa? How do you know that the treatment is working? Gain weight. Is it enough for her to say, well, I feel a whole lot better. I feel better about myself. I'm not afraid to gain weight anymore. That's not your goal. You know, that's like a hospital saying, oh, we're a really good hospital. You got to have the outcomes. How many, you know, so with these patients, you got to work through their fears and all, and the way you know that their treatment is working is if they gain weight. Physical symptoms, weight loss 15% below the ideal. Amenorrhea, will not be having a period if they're in this starvation state. Just think everything's kind of running on a slower mode because they're starving. Okay, so you're going to see bradycardia, low body temp, sunken eyes, dry skin, constipation, can't get warm, don't have any body fat. Now, psychologically, when you're assessing this patient, they're gonna be in denial of the serious weight loss. I ain't lost that much weight. No, no, I'm just thin. I lost a couple of pounds, but it was nothing I was kind of sick with it. So denial of the weight loss, body image disturbance, they're gonna think they're fat. Constantly striving for the perfect body. Their concept of their self is all about this perfect body shape, this image they have. And delayed psychosocial development, very little interest in sex or relationship. Excuse me. So what do you do when you treat these people? They're gonna be on a really strict regimen. A lot of times there's just units that handle nothing but eating disorders. Very strict regimen, and it needs to be focused on changing their eating behavior. We want to work on how they think, and we want to work on how they feel, but they're going to die unless you work on and fix these behaviors. If they will just eat and all, you can work on all that other stuff, but strict times. And so these type units or this type regimens to be strict times that they eat, strict menus, and they're going to be observed while they're eating and afterwards. So, they know that y'all's main goal is to make this person eat. Meds have really not shown to work really good with this, but you may see fluoxetine or Prozac used to help with kind of the OCD type symptoms. In the food and the compulsion, until you get them to an ideal body weight. But meds have been shown limited effectiveness. Binge eating. 1/4 to 1/3 of people with bulimia, we're talking about binge eating, but I'll throw this in. 1/4 to 1/3 of the people with bulimia, like this young lady, had anorexia nervosa before. So it's almost like, well, okay, I'll start eating, but when I decide I need to, I'm going to purge it up. Binge eating, they don't do the purging. It's just a rapid, episodic, impulsive, and uncontrollable ingestion of large amounts of food over a short period of time, like 1 to 2 hours, just eating everything. And then it's followed by guilt, remorse, and severe dieting. So, some of the other behaviors kind of link with this type of behavior, impulsive personality, some depression. You may see this person with this type of eating disorder has a problem with impulsive stealing, like shoplifting. Now, the purging is recurrent episodes of binge eating and compensatory purging by vomiting or the use of laxatives, diuretics, emetics, fasting, or over-exercise. Must occur at least twice a week for at least 3 months for you to have the diagnosis.
Do you have to have every symptom or just a few? You know what I mean? Like, do they have to have all of that or just a few?
Well, with the bulimia, you've got to have the binging and the purging, and it has to happen. Yeah, and if you look at DSM-5, it'll lay it out. And, it can't just be, last week I had a really bad week and I ate a bunch of stuff and I threw up. You got to meet all the certain criteria. Okay, now with the bulimia, we were talking about anorexia, and we touched briefly on the binge eating, but the big focus is bulimia and anorexia. With bulimia, that's the way to put it, recurrent episodes of binge eating, and then the purging behavior is to compensate. With this person, there's just few outward signs that this is going on. Remember that first question we asked, they have a normal body weight. And they hide that they're doing this. Nobody's going to be like, oh, hang on, I'm going to go vomit, or I'm taking laxatives. So it's well hidden, hardly any signs and symptoms that this is going on. And that's so scary because look at what it could be doing to them. Listen to all of what happens, and then it could be deadly. So, but it's usually not as bad as anorexia, because with anorexia, you're literally starving to death, and by the time you come in, your electrolytes could be so out of whack. But now this is still causing a lot of problems, and it still could have some really bad outcomes. Comorbid conditions of substance abuse, depression, and OCD. But now there still could have signs of fluid and electrolyte imbalances, just like anorexia. And I almost let the things she talked about, hypertension, dysrhythmias, cardiomyopathy, hypoglycemia, menstrual dysfunction, constipation or diarrhea, reflux, esophagitis, tears, dental erosion, parotid gland enlargement. She mentioned something about the little chipmunk thing. She ended up with parotid gland enlargement because she was working those glands so much she's vomiting. So kind of with that, we didn't finish it, but we will finish it Tuesday. Y'all had a long week. Stay on top of all your ATI practice test day, getting your proctor test lined up.